Hi, everyone. It gives me great pleasure to introduce our speaker for tonight, Dr. Helen Jarvis, who is going to talk to us about how we can improve detection and management of liver disease in primary care. And you have the screen, Helen.
Thank you very much, John, and thank you all from Liver North for inviting me to speak this evening. It's a great pleasure to speak to patients and representatives of patient groups, and all of the work that I do is driven by my clinical need as well as the research need for better care for patients with liver disease in the primary care setting. So my name's Helen Jarvis. I am a GP in Bellingham, as John said, and I've also recently been appointed as an academic clinical lecturer at Newcastle University, following on from my PhD at the university. Just a bit of background, before being a GP, I had a short career in hospital medicine and started training in gastroenterology and hepatology. I did a year at the Freeman at the liver unit many years ago. And then when I made the switch into general practice, I was just struck by a couple of things. Firstly, that anyone who had any abnormality in their liver tests, immediately everyone was coming to me, "Oh, Helen, what should we do with this patient? What should we do about this? What do we need to do about that?" And the other thing that struck me is that not much was getting done for these patients in general. So that started and sparked my interest in research in this area. So tonight I'm going to speak to you about how we can try and improve detection and management of liver disease in the primary care setting. Oh, hang on. So the first thing that I just wanted to talk about, and I'm sure most of you are all aware of this, and many of you have seen this graph before or several times before in presentations, but why do we need to improve care for people at risk of or with liver disease in general? Well, it's shocking really, but unlike lots of other chronic diseases, which we're getting better at managing, like ischemic heart disease, respiratory disease, diabetes, where generally the mortality rate from these conditions is falling over time, liver disease is the exception for this. And we've seen, particularly in the last 40 years, a sort of almost exponential rise in mortality rates from liver disease. And this is a disease which often affects young people, of working age, as well as older people, and is really a huge problem. This data on the graph only goes up to 2010, but just to bring you up to speed with more up-to-date evidence, if we look at the Office for Health and Improvement Disparities data, which uses Office for National Statistic data on deaths for liver disease, we can see that the absolute numbers of people who die of liver disease every year continues to rise, 2019, 2020, and the latest data we have on that data set of 2021. So this is a problem, and we need to improve this. And why do we need to improve early detection or the management of liver disease in primary care? Well, we know, unfortunately, that lots of patients who have liver disease actually present for the very first time in what's called decompensated cirrhosis. So at the most severe end of liver disease, presenting with abdominal swelling, tummy swelling, or turning yellow or vomiting up blood. And a significant number of these patients who present in this way, up to 70%, have never seen a liver specialist before. So, and often don't have any knowledge that they'd had liver disease. And we know by this time it's often too late. And unfortunately, nearly a quarter of people who present in this way to A&E or to hospitals with liver disease will die within the next couple of months. So there's a very high mortality if you've left it to this stage before presenting with liver disease. So what are we currently doing in primary care? Well, as I've kind of intimated, my personal experience was that this is very much a kind of reactive medicine at the moment. So things come to us like abnormal liver blood tests, which may be done for a variety of reasons. And there's a variety of reactions to that, or inaction in some cases. And part of the issue is that we as general practitioners are obviously following multiple guidelines for multiple conditions. We have NICE guidelines, we have local guidelines, we have NHS England incentives and frameworks and guidelines. And really, it's a sort of overwhelming situation where if there isn't something very sort of clear and obvious and integrated into the way we work, often we can't find at hand the latest guideline for abnormal liver blood tests, and people end up repeating tests and not acting in a way which we would want them to. So, and it traditionally, really, if you look at the GP training curriculum, the general practice training curriculum, up until relatively recently, and helped by myself and others with an interest, liver disease really hardly appeared at all on the Royal College of GP's curriculum of training, despite there being a section on gastroenterology. So it hasn't really traditionally been prioritised amongst all the other work that we're doing in the primary care setting. If we look more nationally at what's happening, and this is from some of my own work from my PhD, we did a couple of surveys, one back in 2020 and one more recently last year, looking at what regions did in terms of providing liver disease care in the primary care setting. And this survey was sent out to what are called commissioning bodies, so health authorities or clinical commissioning groups, or in the more recent survey, the integrated care boards. So people really in decision-making capacity at more regional levels, and asked them whether they had, for their region, whether they had guidelines in place to find liver disease. We asked them about whether they had guidelines for the interpretation of abnormal liver blood tests, but also if they had guidelines in place to manage patients with risk factors, for example, people with type 2 diabetes, or people who drunk alcohol above a certain amount, or with other risk factors for viral hepatitis. Were they proactively having any pathways of care to help pick up and manage these patients? And these two graphs that are represented here, the one on the left is from 2020 and the one on the right from 2023, are just a geographical representation of whether from the survey answers they gave, they'd had pathways in place to manage liver disease. Sorry, I'm going the wrong way here. And essentially, if they became green on the map, that means they had full pathways of care in place, both for responding to abnormal liver blood tests that patients had done, but also proactively managing and looking for patients with liver disease and referral pathways. And you can see that the majority of England in 2020 really didn't have any pathways in place on a regional level. That's not to say individual GPs and hospitals wouldn't have been working together with their own pathways, but on a regional level, there was no standardized pathways. The difference in the colour in the right-hand graph is because of changes in healthcare structures. Larger areas became responsible for commissioning services between the two dates. So in 2023, there was also a category that there could be a sort of partial or pathway available, but not consistent across a whole area. But essentially, the take-home messages were that there were variable access to tests, variable pathways in place, and a real sort of postcode lottery of care across the United Kingdom, with really quite stark and better levels of pathways of care in Wales and in Scotland as compared to in England. So with that in mind, in terms of that we're not doing things in a systematic way, well, what could we be doing in primary care that we're not? Well, we know we do a lot of liver blood tests on patients, and we at the moment, as I say, that's very much a reactive response to someone presenting with a symptom or monitoring for medication. But we could be requesting those in high-risk patients who we think may be at risk of having liver disease. We could be better following national and updated guidelines, and the graph or the picture on the right is of the British Society of Gastroenterology guidelines for managing abnormal liver blood tests. And we could be trying to more proactively get to a diagnosis, so not just repeating tests, but following a pathway and a protocol to take that test forward and try and work out what's wrong in a more standardized way. And I think probably in the future, there'll be a role for some automation of that process to mean that GPs are guided in terms of which tests to do next based on initial tests. And we'll talk a little bit about one example of that in a moment. But probably the most important thing, some of those 3 bullet points I've already mentioned, I think, are already being done in some areas and with some general practices in conjunction with hospital guidelines and protocols. But really, the big shift has to be about trying to get primary care to look beyond those basic tests and look to assess the level of liver damage in an individual that's coming forward. So we have a situation where often routine blood tests may be fairly normal or only mildly abnormal, and yet the level of damage to the liver that person has is not really shown by that test result. But what we have now are better ways to take forward an assessment of how likely it is that that patient has significant scarring or cirrhosis of the liver. So we do a lot of tests on the liver bloods in primary care already. So we're not testing people. Around 8% of the UK population will have an abnormal liver blood test on their record within the last year. And most of these people will be asymptomatic, so won't have any specific symptoms related to liver disease. And if we look at this data from the Birmingham and Lambert liver evaluation study, which was done several years ago in 2012, and we look at just over 1,000 blood tests that were taken in their primary care settings, and they went and investigated in more detail what ended up happening to these patients and followed them through and tried to reach a diagnosis in these just over 1,000 patients, we can see that the most common cause of these incidental liver function tests that were done in the primary care setting were related to NAFLD, now known as MASLD, so metabolic dysfunction associated steatotic liver disease. Some were, again, combined with those of non-fatty and fatty related to alcohol was also a big cause, but you can see the other common causes there, primary biliary cholangitis, hepatitis B virus, hemochromatosis, and other causes. But of note, nearly half at the very bottom still remained unexplained and a diagnosis hadn't been reached. And the reason these tests had been done in the first place was often for kind of fairly routine reasons, so part of a diabetic review, just a non-specific routine review, a hypertension review. So as I say, most of these patients were not presenting with particular symptoms. So we're doing lots of tests. I said I'd talk a little bit about one approach to taking these tests forward and avoiding that scenario where lots of these blood tests remain unexplained, is to put some sort of automation in place, whereby when the GP requests the blood tests, they also have to tick a couple of boxes to say the age of the patient they're requesting it on, whether the patient has type 2 diabetes, what the patient's weight is, whether they drink alcohol, and whether they've got various other risk factors. And all that information is taken into account when the bloods are being analysed in the laboratory, and then various additional tests are done automatically based on what the first initial tests are and the patient's risk factors. So what ends up happening is, rather than a simple blood test coming back to the GP's inbox, the blood tests come back, but with a little bit of text guiding the GP saying, these were the results of the initial tests, we went on to do these tests, this is the risk the patient has liver fibrosis, this is the likely cause of their disease, and please either refer or please monitor, or everything's okay, or whatever the outcome may be. So one area where they've done this very well is up in Dundee, run by Professor John Dillon, who's a hepatologist up there, and his colleagues, where they've developed this, what they call intelligent liver function testing. And these two graphs here just show that in the kind of group that underwent this training in general practice to use this intelligent liver blood test way of working, they found that 56% came back with a definite hepatobiliary, so liver or biliary tree diagnosis, and most of the others came back with something else. But still, there was about a third that were no diagnosis was reached. But that's opposed to in total in the control group, where 44% were not even rechecked or investigated at all. And if you add those to the ones where no diagnosis was reached, about 60% had no diagnosis reached. So it really improved the likelihood of reaching a diagnosis or the test being acted on in the primary care setting. So other than automation, obviously we're faced with seeing these basic tests in general practice and sometimes not knowing what to do with them, or we may have reached a diagnosis, but we have to accept the fact that there are limits to these basic liver blood tests. So obviously one of the first things we need to do is do a kind of screen to rule out some of the rarer causes that might not be obvious from those immediate initial tests. So looking for viral hepatitis screen, looking for autoimmune liver disease, such as primary biliary cholangitis and primary sclerosing cholangitis and other conditions, autoimmune hepatitis. Once we've done that, rather than just saying, oh, it's none of those rare things and I've just got a little bit of an abnormality, we really need to get into the scenario where we're trying to make some assessment for those with the commonest type of liver disease, MASLD and alcohol-related liver disease, of how damaged the liver is. And we can't tell that from those basic tests. So what we know is liver damage in terms of liver fibrosis is the most important predictor of ongoing likelihood of going on to develop cirrhosis or significant ill health or mortality from liver disease. So trying to make some assessment of whether that patient has fibrosis of the liver is very important. So how can we do that in primary care? Well, we can now, and this is where there's been quite a big shift in the last 10 years or so, where now all GPs should be able to have access to fibrosis testing. And fibrosis testing comes in three main sort of ways. One are what are called the indirect serum markers. And that's essentially where you take groups of the commonly requested blood tests, put them into a calculation. As you can see here, we've got an example of the FIB4 score, where we put in the ALT, the ALT, the AST, and the platelet count into a formula and come up with a score which can give us a good idea or a prediction of how likely someone is to go on to develop significant serious liver disease. There are other blood tests which are more what are called direct serum markers, which the blood test directly measures substances which are released from the damaged liver. They're slightly more specialized and less accessible to general practice, but more and more places are able to request these in the laboratory now and should be able to. And then lastly, we have imaging techniques, specifically transient elastography or FibroScan, which fires a pulse through the liver and measures how stiff the liver is as a measure of how damaged the liver might be. If you asked any GP 10 years ago about any of these tests, they probably wouldn't have heard of any of them. And there's still a huge lack of knowledge around the use of these tests and investigations, but they are now readily available. We've had recent approval from NICE to use FibroScan in the community, and there's a big push amongst the community hepatology world to try and get these tests more readily available and able to request from primary care. So what about testing people proactively rather than just reactively finding abnormal blood tests done for other reasons and thinking, could they have a liver disease? Why aren't we trying to look for people who are at the highest risk and proactively identify these people? Unfortunately, that isn't within the UK guidelines at the moment, although that is slowly changing, but the current NICE guidelines and guidelines don't advocate for screening or case finding for liver disease in high-risk groups at the moment. But the European and more American and international guidelines do. So we're in a situation where if we are following certain European guidelines, we would be, for example, looking for liver disease in all patients with type 2 diabetes. Obviously, the benefit of looking in those at the highest risk is you're more likely to find liver disease. So rather than just being faced with a barrage of 10% of the population having liver tests done for random reasons, and you're having to filter through and finding those who are at the highest risk of liver disease, you're starting off from a position where you know from the big epidemiological studies that different groups are at very high risk of liver disease, and you're picking those people out and saying, we know that you're going to be at higher risk, therefore let's try and find liver disease early in you. So to me, that is common sense. And it's the kind of thing we do in all sorts of areas in primary care. This is our bread and butter work. We do NHS health checks. That's to proactively look for people who might have type 2 diabetes, who might have heart disease, who might have kidney disease. We do all sorts of case finding and screening in high risk groups to look for cancers and things like that. So we're already used to seeing patients who don't have symptoms but are at high risk and trying to find disease. So this would just be an extension of that. And the NICE guidelines for MASLD need to be updated to reflect that. And we need to have a push to try and get liver disease thought of in the same way as other chronic diseases in primary care. So in one area, there have been research in this area of proactively finding people with liver disease across different pockets of the country. One of the first areas to do this was in Nottingham, where they used FibroScan to screen patients who had high risk of liver disease, either because they had risk factors for MASLD, metabolic dysfunction associated liver disease, or risk factors for alcohol related liver disease, or they had abnormal liver blood tests. So they were the kind of risk factor groups. And they scanned about 1,000 patients in this initial pilot phase, and nearly a quarter of them had an abnormal FibroScan. And about a quarter of those, so about 6% of the grand total, had likelihood of advanced fibrosis or cirrhosis, so significant liver disease on FibroScan. And they estimated from looking at the different groups that if they just taken those with abnormal blood tests and not taken those other high-risk group patients, they would have missed about 40%, so nearly half of the patients that ended up having significant liver disease. So my kind of interest in this area is mainly around this kind of what I see as the sort of implementation gap. So we know who the people are who have high likelihood of liver disease. We are already doing these liver function tests, these blood tests in primary care for lots and lots of reasons. We now also have these ways of finding patients with the most significant liver disease with these scoring systems and FibroScan. But when we're still not doing it, there's this implementation gap. So we're not going forward and implementing this care in any kind of standardized way across the country. So a lot of my research has been around what's called qualitative methods. So interviewing GPs and other healthcare professionals to try and answer the why questions. Why are we not doing this? What's holding us back? What could we do differently, rather than just counting the numbers, which is more the kind of quantitative research. So I've done a number of qualitative semi-structured interviews with GPs and other primary care professionals to try and explore their experiences of managing liver disease, or not managing it, but how it may fit into this more long-term condition management that we do for other conditions. And it started off with a group of quite exploratory, just overview interviews to get the general experiences of the GPs and healthcare professionals, to a more kind of focused evaluation to guide a local implementation. So I'm sure some of you are aware of a study that's going on at the moment in the region called the SOLID study, which is headed up by Stuart McPherson, which is implementing a pathway to try and find liver disease in primary care. And I've been very involved in helping him guide that by these interviews, to try and work out what GPs how they could integrate things better. And these interviews have been guided by sort of a theory of implementation as to why things happen in a certain way. So just some brief findings from my work, and I'll just give you the sort of headlines. But essentially, once the interviews are done, there's work in kind of looking through all of the transcripts and picking out what are called themes. So what is coming through commonly from GPs in terms of what's stopping them, or what are the barriers to making care better for liver disease. And the first thing that came across was very much related to these what are called organisational barriers to care. So it wasn't so much that they didn't care about patients with liver disease, or it was more that they felt that there was no framework that had been given to them from on high, from NHS England or from the CCG, from someone else, to say, this is the way we do it, this is how it should be done. And if that framework was there, it was felt that that kind of would drive the care and make it feel legitimate, like someone else had thought it was important. So therefore, a protocol and framework had been developed, therefore they would carry it out. And obviously the big framework scheme in general practice that we work within is something called the Quality and Outcomes Framework, where every year NHS England decides certain areas that we need to focus on and that we need to have meet certain standards in. So, for example, in diabetes, there are loads of standards we need to meet. Checking HbA1cs every 6 months, having a diabetic annual review, making sure they have foot checks, eye checks, various other things. But at the moment, none of those incentives within the whole of the GP quality outcome framework includes anything to do with liver disease. So it was felt that if there was one of these incentivized frameworks, not so much because of the money, but more it would make it feel like it was a legitimate and good thing to do. The second thing that came across was that GPs and healthcare assistants and nurses working in the primary care setting felt that they could find it easier to think about liver disease if they thought about it as part of what's called multimorbidity. So they thought about it in the context of other conditions and diseases and as part of a whole person's long-term condition management. So often patients would have annual reviews for their atrial fibrillation and high blood pressure and asthma and other chronic diseases, and that would all be grouped together in one appointment over the year. And if liver disease could be couched within that, that would make more sense to people rather than creating a whole new way of working for a whole new, as they saw it, a whole new area of disease. And that fits fairly well for certain liver diseases. So, for example, metabolic dysfunction-associated liver disease is obviously very closely correlated to other problems like high blood pressure, high lipids in the blood, type 2 diabetes. So they found it quite easy to visualize that they could, if MASLD was included in that care of that patient, they could quite easily add on another blood test or do something in addition. So as well as looking at the feet and the kidneys, they could also look at the liver, and that would make sense. And to a certain degree also, they were already asking these patients in a holistic manner about their alcohol consumption. And if patients were screening as positively high on that screening tools like the audit tool to look at alcohol consumption, they could see how that could easily fit with, as well as talking about other issues, well, they could mention the liver as well. Obviously, that wasn't quite so clear with some of the rarer causes of liver disease, but it was a starting point that they felt that if it was part of multimorbidity, it would make more sense to them. The other thing that I think, because liver disease had traditionally been quite a tertiary specialty, I mean, John mentioned at the beginning, sometimes it's hard enough even in hospital to find someone with an interest in liver disease. You know, it's very much the sort of transplant centres and the tertiary centres who have an interest. Was that GPs found it hard to kind of see their role in the condition. They weren't quite sure what they could do. They didn't know about the treatments. They didn't know what the benefits were of monitoring. They hadn't heard of kind of the new treatments for hepatitis C, or the fact there were new treatments for primary biliary cholangitis, or that there were specialist clinics. It all just seemed a bit out there and away from what they were doing. And they just saw these liver blood tests and thought, well, it just comes back a bit higher the next time. And I just tell them to, you know, reduce their weight and cut down their alcohol. And I don't know what else to do, you know, so they didn't see their role. They couldn't see their what they were supposed to do within it. Actually, interestingly, the nursing participants that I spoke to could much more clearly see their role, because they were very involved in health promotion and working with patients in a more holistic way to look at all of their risk factors for lots of different conditions. And they could see their role more clearly in liver disease becoming part of their role. So the conclusions from that particular part of my work were really that if we wanted to implement care for people with liver disease in primary care, then we had to kind of integrate it and possibly incentivize it to create these frameworks to sort of sustain that practice and try and incorporate the more common liver diseases into kind of the more multi-morbidity care, so care of the whole patient with all of their different conditions. And we should also work through education and communication to more define what the GP's role was in a disease that they felt was predominantly related to lifestyle, rather than something they could give a tablet for. So really, the next stage of my work, or what I've partly been focusing on as well, is, well, within all of this, we've spoken to the GPs and the healthcare professionals, but what do the patients want? What do they want from their primary care practitioner or from their pathway of care if they're at risk of or have liver disease? So I'm doing some ongoing work, collaborative work in this area with a group from Liverpool, where we're looking at patient preferences around pathways of care for MASLs, for metabolic dysfunction associated liver disease. I'm also, as I mentioned, involved in the SOLID study. And the next stage of work in that is patients who passed through a pathway of care where they've had these tests, the FIB4 and the ELF score, and some of them have been referred on for FibroScan, is talking to them about what do they think about that process, what was done well, what didn't work, how did they feel about receiving test results? Did it affect them negatively? Did it affect them positively? Did it mean they could make certain changes? How did they feel about being referred to secondary care or not? And asking them how they feel liver disease would best fit with other kind of healthcare and long-term condition management. And then also talking and around educating the general public around liver disease. What do the general public who may not have liver disease want? So my wish list in terms of what I want next and what I'm trying to sort of work out the best way to research over the next period of my research is really more of a wish list, I guess, which is really we need to try and educate, but also really now push to influence from the public through to the primary care practitioners, but quite importantly through to those who are in position of health policy, because what's become clear in my work is that it's not the jobbing GP who's sitting there making those individual decisions about what pathway to follow and whether to follow up someone's liver blood tests. It's around the policymakers prioritising this, putting it into frameworks and putting it into a way that means that GPs will just do it automatically. So with that in mind, I really wish that we could standardise and integrate liver disease detection and management into our routine work. And I think we've got a lot of already good evidence that we need to just implement and get on with working with, but also aware that it's an evolving field and we need to embrace this new evidence with the aim to get the right tests to the right populations, make the right referrals and follow up people appropriately. And the overall aim of all of this and what my, career is about, essentially, other than looking after my patients in Bellingham, which is obviously general practice, and I do everything other than liver disease as well, is we need to reduce late diagnosis and with the aim that we need to improve morbidity, so suffering of people with liver disease and death at a young age and at any age from preventable liver disease or treatable liver disease. So with that in mind, thank you very much for listening. I'm happy to take questions. I hope I haven't gone on too long, John, but very happy to take questions.
That's great. Helen, would you like to stop sharing and we'll get everybody's... There we go. So we've got a question already from David.
David Yates. Yes, I'm a heart transplant patient, and I have liver problems. In fact, I had a liver examination today. I've got cirrhosis of the liver arising through the conditions that I have. I mean, I think the idea of the imbalance of testing within the GP practice is a very interesting area, and I'm all for it, and I think you should go for it. The thing that disturbs me about what you're actually talking about is that you actually are going to identify more and more people who actually require specialist liver care or liver intervention. Have we the capacity in the NHS to deal with that at this present time?
Well, funnily enough, that's the same question I get asked when speaking to secondary care clinicians, particularly those that don't have a specific interest in liver disease, and even hepatologists, who some of whom do have a concern that if we find lots more patients with liver disease, how are we going to manage this influx of people that we haven't been seeing? But I think that's the wrong way around to look at it, in a way, in that if someone's unwell and suffering and has a condition, they should have the right to know about that and have access to care in the same way that anyone else would. If we need to increase capacity within the NHS in numbers of people training in hepatology, which has long been pushed for, numbers of people training in gastroenterology with an interest in hepatology, or people in primary care who can deal with patients or look after patients with liver disease at a less advanced stage, then we should. And the only way to know that is to appropriately diagnose these patients at an earlier stage, and then we'll have to work out the logistics of how we manage those patients. But I don't think we can say, oh, well, we can't deal with them, so let's just not.
Right.
I don't actually agree with what you're saying there, because I think the point is that I think the point is that if you're actually producing more and more information for people, and obviously knowledge is power, those people want to know that they can get treatment straight away. There's no point in just saying, oh, well, we don't have the capacity at the present time, but we might in the future. I mean, it's all rather pie in the sky, isn't it? You do have to link the two.
Yeah, and we are working with, so I've been doing some work with the UK Liver Alliance and with NHS England around workforce planning and realising that there is a need for extra capacity and extra people within liver disease care, both from specialist nursing, consultants and training positions within hepatology. So yeah, and that's, that's, like you're saying, probably why we're not doing it routine, a part of the reason that it's not routinely happening at the moment from a policymaker perspective.
Okay, David, you're all right with that?
David?
Yes, that's fine. Thank you.
Okay, so we've got Kate next, and then Joan.
Hello, thanks very much, Helen. I found that very interesting. I would like to speak to the benefits of having a tuned-in GP. I was diagnosed with autoimmune hepatitis over 20 years ago, and that came about from having some blood tests and the liver function test showing up as being just slightly elevated in some areas, and my GP picking up on this very quickly. And in the end, I did go through the private system in the interests of getting fast attention, and had repeat liver tests and also some antibody tests, and then leading on to having a liver biopsy. But I've always been very grateful to the GP for being so tuned in as to not just let this rest and say, well, come back and we'll repeat them in a couple of months, but to say to me, we really should be doing something to follow this up now. So
that's great, and that's what we want for as a GP. I've got no interest in slagging off my profession. There are lots of excellent GPs out there who are very good at monitoring and diagnosing liver disease, but unfortunately it's not across the board and it isn't standardized, and that's what we need to work towards, because it's, for other conditions it is a lot more standardized. There'll be a certain reaction to a rise in blood glucose or a certain reaction to a high blood pressure that just isn't there in that standardized way for liver disease. So I'm glad you had a good experience.
20 years ago, yeah.
Excellent. Well, okay then, Kate.
Thank you.
Yeah. Now, Joan's got a question. She's behind this beautiful banner behind me.
Yeah, I'm just wondering what impact the stigma that is associated with liver disease has on people initially going to the GP because they've got symptoms of what they at that stage don't know is liver disease. But if they got a diagnosis at the GP, the stigma, I don't know, is there an impact? Is the stigma significant in GP practice?
Yeah, I mean, I think it, again, it's probably variable. I think there's stigma on both sides in a way, in that I think some healthcare professionals probably stigmatize or feel that they have to act in a certain way, or don't want to give someone a diagnosis because they're fearing the person will feel stigmatized. So they sort of purposely say, oh, don't worry, I don't think it's because you're drinking, or don't worry, I don't think you've got it's just a bit of fatty liver, don't worry about it, it's okay. And they don't want to kind of, they feel that there's almost kind of an expectation that there's going to be, the patient's not going to want to hear that or feel it stigmatizing. But on the other side, I think that there is still, and there's lots of evidence to show this, not that I've done, but around, you know, a stigma still attached to liver disease, and the kind of idea that everyone with liver disease must be an alcoholic or must have been drinking heavily, and that still sort of persists, I think, amongst some of the general population, which, you know, it is a shame and something we need to work on, because, you know, I always use the analogy of like chronic kidney disease, so kidney damage that can be caused by a multitude of things. There isn't this like constant obsession in kidney disease of saying, well, how did you get your kidney disease? You know, was it because you had high blood pressure, or you were diabetic, or you did this or you did that? Whereas in liver disease is still very much a kind of feeling you have to explain yourself, which, you know, is, I think, outdated, and hopefully we can work towards changing.
Yeah, I've spent quite a bit of time thinking about what's the best way to educate the public about liver disease. I mean, without a doubt, when we get calls here, the first thing people say to us is, I don't drink and I've got this diagnosis, and I don't know what the answer is. I wish I did. But I do think work needs to be done around the stigma.
David, is that all right, John?
Yeah, thanks.
David?
It's Hillary.
Hillary, okay.
It's very, very interesting what you say. David's just been diagnosed today as cirrhosis of the liver. And immediately you think, well, he doesn't drink. Yet with, shall we say, lungs, if they have lung cancer, I don't think, no, you don't think, well, you must be a smoker. I don't think lung cancer has that stigma attached to it. I don't know. I'm just sort of saying it's interesting that sort of, as I say, we immediately sort of, well, I don't drink. Cirrhosis is caused by drink, full stop. But it's not.
That's right.
Of course not. No.
You know, it's sort of.
Can I ask you, David, if you've
point you're making?
Have you had the liver cirrhosis self-management toolkit, David?
No.
Right. And where are you being seen?
Well, actually,
Freeman.
The Freeman. I was seeing today. The thing is, you see, I'm coming up for 84. I have an age problem, you know, plus a 36-year heart transplant.
It doesn't make any difference.
Whilst interventions are possible, it is not being recommended at the moment, because the outcome could actually be worse than the actual situation I'm in at the moment. So it's in abeyance at the moment.
John, we mustn't take up time.
No, we don't take up time here.
Give me a ring when the meeting's over.
We don't have. I'll send you an email.
Okay.
We don't have your telephone.
Yeah. Okay.
Okay. Fine. Right. That would be great.
John,
yes.
John, it's Yvonne here. I'm sorry to interrupt, John, because I can't put my hand up.
No, it's fine.
Remember, I'm in Madeira at the minute, so
I know you are.
It's not playing. I know. It's really tough. But can I just ask a question, please?
Of course you can.
Just picking up from what Joan said there, and Joan said, you know, spent a lot of time trying to sort of educate people and educate the public, educate doctors, whether it be secondary care or primary care. But what Helen said, just picking up again what Helen has said, it's the powers to be, the people who are making those decisions. Now, I've sat in many meetings where, you know, that there've been doctors present. That isn't a problem, but I don't know. Maybe I'm being a little bit naive here. The people who are making the decisions about which tests to have and how the money is divvied up, how do we actually influence them? Does anyone have any idea? Does Helen have any idea how, as a patient, you can actually influence those people?
Well, I mean, I don't have much of an idea other than that because of the interest that I've got and the fact that there aren't that many other GPs with an interest in liver disease. Despite my fairly junior role in an academic sense, I've ended up being invited to various kind of committees and guidelines and things, and one of which is with a group with NHS England. And yeah, the people who have the power are often kind of the civil servants working for the NHS who are not medical and have got huge tranches of money to sort of decide what to do with. The one kind of group of people that seem to be able to kind of get to them and influence them are MPs and parliamentarians. And I think as patient groups and as patients kind of trying to influence your MP and get questions into Parliament, and you know, I know it's very, very difficult, but yeah, politics seems to be the route in, but it's very difficult to know how to get to the right person.
Right, that's very interesting, Helen. That's really interesting. Thanks for that. Yeah, yeah.
Okay, Yvonne. I mean, Helen, what you're trying to do is the right thing, isn't it? You're trying to educate GPs to be able to carry out the tests and to diagnose liver disease earlier. And there is no limit to the tests that the GP can have done. You know, there's a tariff. The clinical commission groups provided that, but you can ask for any test you like, aren't there? There's no barrier to that.
Yeah, no, I mean, there are, for example, when I talked about things like the ELF test, which is this direct marker of damage to the liver, there are only certain laboratories in the UK who actually have the machinery to do that test. So it's physically impossible for us in Northumberland to just tick a box and request that test, unless it's in the context of a research study. And likewise with FibroScans, different areas will have different ways of tariffs and payments for that. So in some places in Northumberland, for example, we can, a bit like requesting an ultrasound or an X-ray, we can request a FibroScan without a consultant hepatologist saying yes or no, they do or don't need one. And then the result will come back to us for us to decide whether or not to refer on to hepatology. But in other areas, you could only get that in a clinic, in a hospital, often a tertiary hepatology hospital, not even a local district general hospital. So it varies across the country, but not because we as GPs think we can't afford that, we don't want to pay for them to have that test, just physically, we can't physically request it.
Yeah, well, we always, with the helpline, we tell people to, that they have a patient choice and they can go to a hepatology centre, you know, they can go to a liver unit. And we always tell them that that's where they'll get the best advice for liver disease. And that's something all of our helpline workers regularly tell people, because we know it's for their own good. I know it's further to travel, but you can have any test you like once you're at a liver centre. The other thing I wanted to say was, for a long time, you know, this is really the fatty liver disease side of it is, and that's the wrong word, I know, is lifestyle choices, and our consultants say it's the worst script they ever have to write is to say the Mediterranean diet, get some exercise. They would rather give them a tablet or an injection or a syringe drive or anything rather than that, because they know that people are not going to take it seriously. And if only we had something that would be a silver bullet, you could cure it.
I mean, there are obviously, in terms of medication, there's now the first medication specifically licensed for metabolic dysfunction associated steatotic liver disease, MASLD, has been licensed by the FDA in America recently. And there are obviously now weight loss injections and things like that. But I think going back to the kind of lifestyle advice, the problem is, again, and it comes back to kind of resource. It's, you know, like you say, saying to someone, oh, you know, go and have a Mediterranean diet and lose weight. It's like you're not taking into account someone's like life context. First of all, people have budgets that they have to stick to for buying food. People might not have access to going to a gym. They may have other comorbidities, which mean they've got arthritis and they can't move around. There's all sorts of reasons why people might not be able to just take on board that advice. And actually, lots of the evidence in terms of that sort of, if you're going to use that as an intervention, shows you have to treat it in the same way that you would treat another intervention, which is it has to be supported. It has to be someone there helping, access to a phone line, regular weigh-ins, regular checkups, helping people out with how they might best go about things for their own personal circumstances. It can't just be like, in the clinic, tick the box, oh, I've told them to lose weight and stick to a Mediterranean diet. That's just not, that's not any sort of intervention. That's not,
Mm-hmm. Well, we had the alcohol clinic at Newcastle was doing brilliantly when Chris Day was there, and he had brief intervention. There was the two nurses we knew used to see people once a week. And I'd come back with the diaries, and it really had great effect. And it's a similar kind of thing needed, isn't it? When somebody can help you and monitor you and try and guide you along the road, but we just haven't got the people to do it. Anyway, any more questions, anyone? That's absolutely brilliant, Helen. I think you're really trying hard. Cressida, you have a question? You have to unmute, dear. Unmute you, that's it. Keep trying. We've got a question coming once Cressida finds out how to unmute.
Yeah.
There you go. Well done.
You hear me? Yeah. What are these liver centers? Where are they?
Sorry, say again, Pat.
What are the liver centers that you mentioned?
Where are the liver centers? Right. Do you want the nearest one to you, or do you want all of them?
London or
Yeah, London is King's College.
King's College. Okay.
The Royal
Free, yeah. Where else, Helen?
Well, King's College and the Royal Free would be the two biggest
main ones, yeah.
There is a liver unit at Barts in the London as well.
Yeah.
Barts, okay. So can you just refer yourself?
Sorry, say again, Pat.
Can you just refer yourself?
You can ask the GP to refer you. You've got patient choice for secondary care. For primary care, if you're injured, you have to go to the nearest A&E department. If it's secondary care and the GP thinks you need to see someone, you can choose where to go.
Okay.
You have to discuss it with your GP.
Right. Okay.
Okay.
Yes, thank you.
That's great. So, all questions finished? That's brilliant. I'll stop recording now, but don't go quite yet.